Good afternoon and welcome to the American Academy of Physical Medicine and Rehabilitation webinar series. Thank you for joining us. Today we're going to talk about understanding MACRA, the Medicare Access Chip Reauthorization Act of 2015, and specifically the Medicare Payment Reform Law that's before us. We plan to provide over the next 40 minutes or so a top-line review of the legislative and regulatory dynamic moving forward. And later on in the presentation, and probably most important, we will highlight the two areas in which most of the important initiatives will take place, and that is the merit-based incentive payment system and alternative payment model. Today's presenters are Melanie Dolak, Kavitha Nurakonda, and Paul Smedberg. Today's agenda, we're going to look at post-SGR, sustainable growth rate, and the importance of MACRA, MACRA legislative overview, and as I said earlier, the importance of MIPs and the ATMs, and finally, we'll give some thoughts on implications and expectations moving forward. First, let's provide a little historical background on Medicare's sustainable growth rate. After 14 long years of lobbying, 17 short-term patches, and sustained and united advocacy efforts from the medical community, a bipartisan leadership deal passes Congress. And this bill repeals the sustainable growth rate, which was part of the landscape for the last 14 years. And that bill was signed into law on April 16, 2015 by President Obama. So at that time, the SGR was dead. So to give you a brief timeline, in 1997, the SGR was implemented. In 2015, the SGR is now repealed. And beginning in 2016, MACRA implementation will begin. So now we have what we're calling a new normal. In January of 2015, HHS announced a goal to move the Medicare program and the healthcare system at large toward paying providers based on quality. And by the end of 2016, 30% of Medicare payments will be tied to ATMs or bundled payments. And at the end of 2018, up to 50%. This is the first time in history that a Medicare program at HHS has set explicit goals for ATMs and value-based payments. So let's review the Medicare Access and Chip Reauthorization Act, the various sections of that. Most important, of course, are the MIPs, the ATMs, the QCDR, the electronic health record or meaningful use, physician group practices, etc., are all at the center of the new MACRA. Providing, and the goal is to provide high quality care, high value health care. And you will be required to participate in these new payment and delivery models. There is an emphasis on new measure development and quality reporting. The AMA and several other peer societies are reprioritizing efforts to address MACRA. I think it's fair to say that the passage of this bill by Congress caught many people off guard, and now this new normal is forcing several medical societies to reprioritize how they look at policy and are looking at payment and quality measures. And they are really focusing in on this in a relatively short period of time, as is the Academy. So first, one of the important things that the MACRA does is it stabilizes the fee updates. So payments, there'll be an annual payment update of 0.5% per year for the first 4.5 years. So from July 2015 to 2019, there'll be a 0.5% increase. In 2020 through 2025, your payments will freeze, and then picking up again in 2026 and beyond, medical professionals could receive or will receive a 0.5% annual increase, but only if they participate in APMs. If not, there'll be a 0.25% base increase. MACRA also consolidates Medicare quality programs. The new merit-based incentive payment system, the MIPs, It'll sunset the PQRS, the VM, and the electronic health record penalties in 2018, and it will create a new composite score, which you will all be judged on. MACRA also will create an additional bonus pool of funds, approximately $500 million a year, for the top performers participating in this program. Now, the cost of MACRA is $213 billion, and this is offset by approximately $70 billion in savings that they estimate from the implementation of this program. But more importantly, and something that would be of interest to a lot of our Academy members, it also includes $15 billion in savings from post-acute care providers. And we'll be hearing more about that in other webinars and information coming from the Academy. So this is to say, really, that the bill that passed Congress is budget neutral, which means this program is not supposed to cost the government or the taxpayers any money. So through the implementation period over the next decade or so, you'll be seeing various initiatives that will be put up for review and final and comment that will get at bringing efficiencies into the program. Other provisions in MACRA include, or will include, access to information on physician and data availability, Medicare claims data available to clinical data registries. CMS will publish quality, resource use, and payment data on the Physician Compare website, and this is going to be something that will be made readily available to the public, so they will be able to see how you're comparing with your other physicians in your area and around the country. It reverses CMS decision to eliminate the 10 and 90-day global surgery payments. It requires electronic health record interoperability by 2018, and that is something that I know CMS will be focusing in on very carefully, as will the various medical societies, including the Academy. It boosts physician fees in rural areas of the country through 2017. So for those who may not have the ability to, or who are challenged by having to travel long distances, potentially to staff clinics, and may not have the resources to pay for a lot of the implementation that is going to be required by a practice or a group practice or a clinic to conform to the new MACRA rules, there will be fees to help pay for some of that. And it also allows CMS to use the Probe and Educate program to assess compliance with the various MACRA regulations. And basically this is an audit, so they will be able to use this to make sure that you are following and providing all the information that's required for proper reimbursement. So here's a MACRA timeline, and this is something that will be handy for you to keep around and look at as you're thinking about how you operate and how you manage your own practice or work within your own clinic. So in 2017 or 2016, final rules for APM and MIPs will be determined. CMS will likely propose rules in the spring of 2016, open them up for comment, and then have, and ideally they'd like to have final rules published by the end of the year. There will be technical assistance funds available for practices, again with help with implementation. In 2017, there'll be a collection of global surgery code data, and MIPs and APM reporting will begin. In 2018, the electronic health record interoperability will start. And in 2019, the MIPs, the APM bonus and penalties will be imposed, and you'll be hearing more about that later in the more detailed presentations in those two areas. And the MIPs will become the only Medicare quality reporting program. So what does the future look like? I think regardless of one's perspective, several things are clear. MACRA is now the law, and over time, because of the budget neutrality requirement, there will be less money in the payment system. So you're going to be required to do more with less. To remain financially viable under MACRA, providers must find ways to improve the value of the care they provide. And this is really a main foundation block for all of this, and this is something that we together will have to work on. And lastly, providers must consider their relationships with one another, with hospitals, and with the healthcare system at large to make sure that you are a vital part of whatever system and whatever environment you're working in. So the future is now. And I'm going to read a quote from a PM&R Journal article back in September of 2015, which we think summarizes where we are right now and where physiatrists and the academy will have to go in the future. Physiatrists will need to find ways to improve the efficiency and effectiveness of care provided within larger systems while concurrently improving patient satisfaction with that care. In particular, physiatrists will need to prove and articulate their value, which will mean identifying and defining optimal pathways or mechanisms for physiatric care and producing data that proves their worth or your worth. This is no small task, and it is one best taken on collectively by the field. And we think that really summarizes where we need to go moving forward. And next, I'd like to turn the presentation over to Kavitha Nurakonda, and she will describe in much more detail the merit-based incentive payment
system. We'll call it MIPS. In an honest effort, we think, to make our lives easier, MIPS was created to roll up the disparate CMS incentive programs that exist today. These are Meaningful Use, the EHR Incentive Program, the PQRS, Physician Quality Reporting System Program, and the one program that none of us truly understand, the Value-Based Modifier Program. MACRA also allocates $75 million for measure development to support MIPS and the movement towards pay-for-performance for the entire healthcare continuum. What's clear for the MIPS program is that it will largely be administered at the individual or national provider identifier level as opposed to the tax identifier level. Currently, there is some overlap between the use of the NPI and the TIN for different reporting programs. CMS plans to start with the usual suspects in the 2017 reporting year. Starting in the 2019 reporting year, basically anyone with an NPI number will be subjected to the MIPS program. There are some providers that will escape the requirements of MIPS. Although they may be happy to be excluded from MIPS in the short term, they won't be able to hide from it forever or from the movement of tying payment to quality and cost in general. And for the first time, consumers will be able to see their providers rated on a scale of 0 to 100 and how their providers compare to their peers nationally. This level of transparency goes well beyond the current information publicly available about physicians. MIPS simplifies the application of incentives and penalties for the Meaningful Use, PQRS, and the Value-Based Modifier programs, while continuing to measure performance as specified by each of the three programs. Total scoring for the MIPS program will range from 0 to 100. There are 4 categories that physicians will receive scores for. There will be a phased approach for scoring for the quality and resource use categories for the first 2 years of reporting, with more emphasis on quality reporting through the PQRS program than the value-based modifier resource use measures. Starting with 2019 reporting and beyond, quality and resource use measures will be equally weighted. The meaningful use category is described as where physicians can earn a maximum of 25 points for complying with the meaningful use requirements in a particular performance year. The quality category is defined as physicians that can earn a maximum of 30 points for meeting mandatory PQRS quality reporting requirements and the value-based modifier measures. In the resource use category, physicians can earn a maximum of 30 points that will be determined based upon the value-based modifier cost measures. And then a fourth category, a new category, is the clinical practice improvement category. There is a lot of uncertainty as to what may constitute a clinical practice improvement activity. I'll go over a few of what we expect this to look like next. But you can now see how the total maximum score of 100 can be attained. The first three already have the green light to be tied to a qualified clinical data registry participation by an eligible professional. We can talk more about this later. But more importantly, including all of the categories into a clinical practice, qualified clinical registry, will be important in the future. So what is the clinical practice improvement category? You'll see on the slide a very broad list of activities that may be applicable to meet this requirement. CMS is expected to define these categories better in the summer of 2016. You'll see that maintenance of certification is listed here as an example. There have been some boards accepting participation in a qualified clinical data registry to meet the requirements of MOC. Here's just another area where clinical data registries are becoming an integral part of reporting programs. Also, participation in a patient-centered medical home gets automatically the highest score for the clinical practice improvement category. So we, the Academy and Physiatry, need to define what it means for a physiatrist to participate in a patient-centered medical home or become a part of a medical neighborhood, to get the appropriate approvals to do so, and to provide resources to our members to do this successfully. So the bottom line is that this is what scoring is going to look like for MIPs in the 2019 reporting years and beyond. While it's important for us to know the nuances to share with everyone between now and 2019, we must aim towards being prepared for this particular breakdown of MIP scoring. And not only do we need to continue meaningful use, PQRS, and the value-based modifier ties to clinical data registries, we need to move towards the clinical practice improvement activities and define what those are to be tied to the same registry work as well. Scoring. What's scoring going to look like for MIPs? Each category is weighted differently. During a benchmark year, we anticipate that will start in 2017, and penalties and incentives will be realized in 2019. Every provider in the country will be scored. Next, the mean or median, depending on which is chosen, of the nation's providers will be determined. That figure will become the performance threshold. If a MIPS score exceeds the threshold, then you can pat yourself on the back. Your Medicare Part B fee schedule will be higher than what's published. On the other hand, if your score is below the threshold, you can expect a haircut on your entire Part B book of business. It starts to get really interesting, or maybe more confusing, when talking about the dollars at stake. If the MIP score is less than 25% of the threshold, the maximum penalty will be applied. If the maximum penalties in MIPs applies to you, in 2019, when that first MIPS penalty is applied, please note that it starts at a lower amount than it currently is right now. CMS is starting the clock over again on how penalties will be realized starting in 2019. If your score is between 25 and 99% of the threshold, you will face a linear declining penalty. The closer you are to the threshold, the lower your penalty. If your score is identical to the threshold, you face no penalty. If you exceed the threshold, you get bonuses rising in a linear fashion. Note that MIPS is a budget-neutral program. The number of dollars collected from providers below the performance threshold will determine the scale for bonuses. The scaling factor can be as high as 3 times. If that happens in 2022, physicians with a perfect score of 100 can receive a 36% higher fee schedule payment than those who are receiving penalties. We have never seen a program with the potential for this much spread. There are some opportunities under the MIP program. CMS is allocating $75 million for measure development for the MIPs and the MACRA program overall. We, Physiatry, are being more and more accepted to being a part of the CMS work groups that develop measures. However, being just a participant has not given physiatry or many specialties much control over the outcome of measures implemented into PQRS. So the focus needs to be on what measures will be implemented in the future and how will we, physiatry, play a big role in impacting what the specifications of these measures are. In summary, here's the timeline for reporting MIPs. As daunting as MIPs appears, there is another and maybe an even preferred path to meeting the payment tied to quality and cost requirements, and that is the option of alternative payment models. One thing is for certain, and a common theme, regardless of if we are examining MIPs or alternative payment models, is that quality measures that must be reported on will be tied to payment. I will hand it off to Melanie now to discuss what we know about alternative payment models.
While CMS and other regulators are still sorting out the details of MACRA implementation, I will explain what we know at this time about APMs and what the Academy is working on to help our members. Clearly, Congress is convinced that costs will decrease and quality will increase if physicians participate in APMs. To further encourage physicians to participate in APMs and to help offset investments or other costs they may incur, the MACRA legislation provides 5% bonus payments from the years 2019 to 2024 for those who join new models. 2019 to 2024 is considered a transition period meant to support successful implementation of new models. Therefore, this bonus is in addition to the 0.5% annual update for those years and is also on top of any extra revenue the physician receives as a result of being in the APM, for instance, through generating savings or through monthly per-patient payments. Following the transition period, as Paul mentioned, beginning in 2026, physicians in APMs receive annual payment updates of 0.75%, whereas other physicians receive payment updates of 0.25%. There are some hurdles to overcome in order to receive a bonus during the transition period. To qualify as an APM participant, physicians must meet increasing thresholds for the percentage of their revenue they receive through qualifying APMs. In the first 2 years, 2019 and 2020, to fully qualify as an APM participant, 25% of patients or of Medicare revenue must be through qualified APMs. In years 2021 and 22, the threshold grows to 50%, and in 23 and beyond, the threshold is 75%. There are some caveats to these provisions. For one, physicians who are close to the thresholds can partially qualify. Second, the legislation says that threshold levels may be met either through Medicare APMs alone or in combination with other payers' APMs. In addition to the bonus incentives, as Kavitha already mentioned, you are exempt from MIPs if you are participating in a qualified APM. You are also only subject to the quality reporting requirements stipulated for the APM. There are some other interesting provisions or advantages in MACRA to support APM development. Starting in 2016, technical assistance funding of $20 million is available through fiscal year 2020 to assist small practices to participate in APMs and in MIPs. Small practices are defined as including up to 15 professionals. Also, telehealth services will be covered in an APM, even if the service is not otherwise covered by the traditional Medicare program. MACRA lays out 3 key requirements for qualified APMs. It requires use of a certified electronic health record. It requires use of quality measures that are comparable to measures used in the MIPS program. It also calls for the participant to bear more than nominal financial risk. As with many aspects of MACRA, we are waiting for CMS to provide further clarification on these requirements. For instance, what constitutes nominal risk is unclear at this time. In a moment, I will talk more about when we anticipate getting clarification on all of these requirements. But first, I want to provide the specific examples for qualified APMs that are outlined in MACRA. As shown on this slide, APMs include Medicare Shared Saving Program, ACOs, all CMS Innovation Center initiatives except Healthcare Innovation Awards, and certain demonstration programs. An important additional note is that physicians participating in patient-centered medical homes authorized by the Centers for Medicare and Medicaid Innovation qualify for bonuses and do not need to bear financial risk. The Academy is researching all of these models to determine what opportunities there are for physiatry to participate in them. One concern that specialties have is how physicians will get approval for qualified APMs. MACRA creates a physician-focused payment model technical advisory committee that will be charged with reviewing proposed models. 11 members have just been appointed by the Government Accountability Office to this committee. CMS has also released a request for information in advance of plans to publish a proposed rule and final rule to establish the criteria for reviewing and approving APMs. MACRA requires that the criteria be established by November of 2016. The Academy is currently preparing a response to the request for information. Specialty societies have expressed many concerns to CMS regarding APMs. While not exhaustive, this list provides some of the risks that physicians will need to consider before participating in APMs. This includes, will APM payments be adequate to cover services patients need? Will risk adjustment be adequate to control for differences in need? How will costs of other APM providers involved in patients' care be controlled? What portion of payments will be withheld based on quality measures? And will the practice have enough patients in the APM to cover the cost of managing the new payment and get the 5% Medicare bonus? There are many unknowns about APMs that will be addressed in future rulemaking. The Academy is working to get clarification in the meantime in several key areas to help our members participate. At the top of our list is to get a definition for alternative payment models and identify pathways to get models approved. We also want to understand how the criteria for meeting more than nominal financial risk will be defined. We are trying to determine if physicians need to be in an alternative payment model by 2017 in order to qualify for bonus in 2019, similar to the MIPs reporting requirement. This is important to understand because physicians may need to prepare to meet qualifications for MIPs in 2017 in the event that they are not able to be in a qualified APM by 2019. Finally, we intend to provide more information about how members can qualify for technical assistance funding to develop their models. The American Medical Association and all medical specialties, including the Academy, have accelerated their efforts to help physician practices to develop alternative payment models. They want to identify or develop enough APMs so that physicians, including both independent and employed physicians in all specialties, have at least one APM in which they could feasibly participate in order to qualify for incentives starting in 2019. Along those lines, the AMA has formed an APM work group, and the Academy has a seat on that work group along with family physicians and internists, surgeons, otolaryngology, oncology, emergency medicine, psychiatry, urology, and 4 state medical associations, including California, Washington, Wisconsin, and Massachusetts. This timeline provides a reminder of the APM provisions we have discussed, including formation of the Technical Advisory Committee this year, the availability for funding for small practices next year, and the first year of APM bonus eligibility, which will be in 2019. As we have discussed today, physicians participating in the future Medicare program will have to choose one of 2 value-based payment pathways, either APMs or MIPs. While the ultimate goal of MACRA seems to be to attract more participation in payment models, those who do not have that option or choose not to be a part of new payment models must participate in MIPs. As we have pointed out, even if one participates in MIPs, there is an opportunity for greater incentives via the clinical practice improvement category by participation in an alternative payment model. The Academy's Board of Governors has designated MACRA implementation as a top priority for the time being. We will continue to provide timely information to you as we learn more about the MIPs and APM pathways. Thank you very much for your attention. Should you have any questions, please visit the Academy's website at www.aapmr.org at any time, or call the Academy's headquarters at 847-737-6000 and ask to speak to someone in the Health Policy and Practice Services Department. Thank you again.